Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of otitis media with effusion, commonly known as glue ear, designed for general pediatricians. This is one of the most common conditions in childhood, yet it is frequently underdiagnosed because it can be silent. We will walk through 10 carefully crafted clinical scenarios covering recognition, examination, pathophysiology, investigations, including tympanometry and audiometry, differential diagnosis from acute otitis media, medical and surgical management, complications and special at-risk populations. Let us begin. Question 1. A 5-year-old boy is brought in by his mother because his teacher noticed he has been daydreaming and asking for instructions to be repeated. He has no ear pain, no fever, and no recent upper respiratory infection. On examination, he appears well. What is the most likely diagnosis? Option A, otitis media with effusion. Option B, acute otitis media. Option C, chronic suppurative otitis media. Option D, behavioral hearing loss. The correct answer is option A, otitis media with effusion. Otitis media with effusion is often asymptomatic and presents subtly with mild conductive hearing loss rather than overt ear complaints. Children are frequently detected through behavioral changes such as daydreaming, inattention, turning up the television volume, or asking for repetition. Importantly, this condition lacks the acute signs of infection like pain or fever, which distinguishes it from acute otitis media. It has a very high prevalence in preschool children due to anatomical and immunological factors. On otoscopy, you will typically see a retracted tympanic membrane with a dull amber appearance and sometimes an air fluid level behind the membrane. Question 2. A 3-year-old with suspected hearing loss undergoes pneumatic otoscopy. Which finding is most characteristic of otitis media with effusion? Option A, highly mobile tympanic membrane with insufflation. Option B, bright red, bulging tympanic membrane with obscured landmarks. Option C, impaired mobility of the tympanic membrane. Option D, perforation of the pars tensa with active discharge. The correct answer is option C, impaired mobility of the tympanic membrane. Impaired tympanic membrane mobility on pneumatic otoscopy is the most sensitive and specific clinical finding for middle ear effusion. When you puff air against a normal tympanic membrane, it moves briskly inward and outward. In otitis media with effusion, the fluid behind the membrane dampens this movement. The tympanic membrane may appear retracted, neutral, or slightly full, but it is rarely bulging, which differentiates it from acute otitis media. The presence of air fluid levels or air bubbles behind the membrane is pathognomonic. The color of the membrane often appears amber, yellowish, or dull gray rather than the bright red seen in acute infection. Question 3. A 4-year-old girl with recurrent otitis media with effusion is found to have enlarged adenoids. What is the primary pathophysiological mechanism by which adenoid hypertrophy contributes to the development of glue ear? Option A, direct bacterial invasion of the middle ear space. Option B, increased production of cerumen in the external canal. Option C, overproduction of perilymph in the inner ear. Option D, mechanical obstruction of the eustachian tube orifice. The correct answer is option D, mechanical obstruction of the eustachian tube orifice. Eustachian tube dysfunction is the central event in the development of otitis media with effusion. Adenoid hypertrophy causes mechanical blockage of the nasopharyngeal opening of the eustachian tube and also serves as a reservoir for bacterial biofilms that perpetuate inflammation. When the tube cannot ventilate the middle ear, negative pressure builds up, leading to fluid transudation from the mucosal lining. Children are particularly susceptible because their eustachian tubes are shorter, more horizontal, and floppier than those of adults, making passive drainage and ventilation less efficient. This explains why glue ear is so common between ages 2 and 7 and tends to resolve as the craniofacial anatomy matures. Question 4. You perform tympanometry on a child with suspected middle ear fluid. The resulting graph shows a flat line with no identifiable peak, which is a type B curve, and a normal ear canal volume. What does this result most likely indicate? Option A, normal middle ear function. Option B, presence of middle ear effusion. Option C, negative middle ear pressure due to eustachian tube dysfunction. Option D, tympanic membrane perforation. The correct answer is option B, presence of middle ear effusion. A type B tympanogram, which is the flat tracing, indicates a non-compliant middle ear system, and the most common cause is fluid filling the middle ear space. The key distinguishing feature here is the normal ear canal volume. A normal ear canal volume rules out a tympanic membrane perforation or a patent ventilation tube, which would otherwise produce a flat tracing but with a very large ear canal volume. A type A tympanogram represents normal middle ear function with a sharp peak around zero pressure. pressure. A type C tympanogram shows a peak shifted to negative pressure, which indicates eustachian tube dysfunction and is often a precursor or sequel to effusion. Tympanometry is an objective, quick, and child-friendly tool that powerfully complements pneumatic otoscopy. Question 5. A 6-year-old child has had bilateral otitis media with effusion for 4 months. Audiometric testing is performed. Which type of hearing loss is most expected in this patient? Option A, conductive hearing loss. Option B, sensorineural hearing loss. Option C, mixed hearing loss. Option D, central auditory processing disorder. The correct answer is option A, conductive hearing loss. Otitis media with effusion typically causes a mild to moderate conductive hearing loss, usually in the range of 15 to 40 decibels. The fluid in the middle ear acts as a physical barrier that prevents efficient sound wave transmission through the ossicular chain to the inner ear. On the audiogram, this produces an air-bone gap, where air conduction thresholds are worse than bone conduction thresholds, while bone conduction remains normal because the inner ear itself is unaffected. The good news is that hearing usually returns to normal once the effusion resolves. However, when the hearing loss is persistent, particularly during the critical period of speech and language acquisition, it requires careful evaluation for developmental delays and may prompt earlier intervention. Question 6. A mother asks how to tell if her child has glue ear, that is otitis media with effusion, or a real ear infection, meaning acute otitis media. Which clinical feature is most helpful in distinguishing acute otitis media from otitis media with effusion? Option A, presence of fluid behind the tympanic membrane. Option B, hearing loss in the affected ear. Option C, acute onset of symptoms like ear pain and fever. Option D, abnormal tympanometry results. The correct answer is option C, acute onset of symptoms like ear pain and fever. This is a critical distinction because the two conditions look similar on a superficial level but require very different management. Both conditions involve fluid behind the tympanic membrane and both can produce abnormal tympanometry and hearing loss, so those features do not separate them. What truly distinguishes them is the presence of acute inflammation. Acute otitis media is characterized by acute onset of otalgia, fever, irritability, and poor feeding with a bulging, opaque, and erythematous tympanic membrane on otoscopy. Treatment involves analgesia and often antibiotics. Otitis media with effusion, in contrast, lacks acute inflammation. The child is usually systemically well. The membrane appears retracted and amber with an air fluid level, and management is watchful waiting with no antibiotics. Otitis media with effusion is often a sequel to acute otitis media, persisting for weeks after the infection has cleared. Question 7. A healthy 2-year-old is diagnosed with otitis media with effusion following a mild cold. There are no developmental concerns. According to clinical practice guidelines, what is the recommended initial management? Option A, immediate course of oral amoxicillin. Option B, daily administration of oral antihistamines and decongestants. Option C, use of intranasal corticosteroids for 4 weeks. Option D, watchful waiting for 3 months. The correct answer is option D, watchful waiting for 3 months. Watchful waiting for 3 months from the time of diagnosis or effusion onset is the standard of care for otherwise healthy low-risk children. The reason is simple and powerful. Spontaneous resolution occurs in 75 to 90% of cases within 3 months without any intervention. Multiple high-quality studies have shown that antihistamines, decongestants, and oral or intranasal corticosteroids are not recommended due to lack of efficacy and potential side effects. Antibiotics may provide only a small transient benefit and are not routinely indicated because otitis media with effusion is not primarily an active bacterial infection. During watchful waiting, the pediatrician should provide caregiver education, safety net advice, and reassessment, returning earlier if symptoms worsen or persist. At the 3-month follow-up, most children will have improved spontaneously. Question 8.